My name is Joel M. Roman. I am a 19-year old, yeah, I wish, a 19-year thyroid cancer survivor. Um, and I am the facilitator for North Los Angeles County ThyCa support group. Um, Today's session it's an interesting session, and I don't know that we've ever had a session on tumor boards before. To me, it's a big black hole that you feed your patient information in, and a bunch of people talk about you, and then it all comes out as the judges come back from their chambers. Let me just briefly introduce the people who will be speaking today. Dr. Michael Ye is the chief of endocrine surgery at UCLA Medical Center. Um, he has been a speaker at our support group, and he's been in here um, once, and he is sort of going to kind of chair this thing. Angela Leung is an assistant professor of medicine at UCLA, the David Geffen School of Medicine. Went to Boston University, and she's particularly interested in thyroid disorders, including parathyroid and adrenal disorders. We don't hear adrenal too much in these conferences, and various other thyroid issues. And Dr. Livhits, who works with Dr. Ye as an endocrine surgeon at UCLA, um, went to my dad's med school in Missouri, and she and Dr. Ye actually have participated in quite a few online sessions for over the years for the general public medical sessions that UCLA hosts. So with that, I am going to turn it over to Dr. Ye and let him kind of run the meeting here, and I'm going to take myself off the picture here and let you just have at it, Mike.
Sounds good. Can everybody see my screen now? I hope everybody can hear me. And the title of our session is a patient-focused tumor board for this year's virtual ThyCa meeting. So here's the question. Joel put it so well. Tumor board can be this kind of black box, and we kind of wanted to demystify the black box. It seemed like it would be a more fair thing to do. So what really happens when your case gets presented at tumor board? And we want to make sure you know how friendly it is. There are a number of patients, I see of our patients on the attendee list today, and several of their cases have been presented at tumor board. A few of them have agreed to have their cases shared. So you've already met our faculty. Here are our disclosures, nothing too exciting. And here's what tumor board looks like. At least pre-pandemic, it looked like this. So tumor board is a working multidisciplinary conference, as we get a bunch of people in a room. Sometimes we eat some tuna sandwiches. And this crowd represents everybody from all the various disciplines, different training backgrounds and skill sets, who can contribute value to the care of our thyroid cancer patients. We have a big screen, and literally before the tumor board begins, so who are the representatives? Let's get into that. So endocrinology, those endocrinology doctors are most often the quarterback. Endocrine surgeons and head and neck surgeons are present. These are also known as the neck invaders, as Joel said. Nuclear medicine is there. They administer, this is obviously an oversimplification, right? They administer radioactive iodine, and they help us with functional scans, such as radioactive iodine scans and PET scans. Pathology, an increasingly important role. They analyze every tissue we biopsy, everything that we remove from the neck surgically. Pathology is analyzing. I know a growing role for pathologists is molecular testing results, which are more and more common. You probably heard about that at other sessions. Radiology is there to perform scans and help us to interpret scans. Radiation oncology, they're the ones that give external beam radiation therapy, such as SBRT. Medical oncology, and those are the people that give chemotherapy, including targeted agents. So everybody you need is there. What's the workflow? Well, we hold at UCLA, we hold this conference at first Wednesday of every month, and anyone could submit a case. I mean, literally anyone. It could be a UCLA doctor, it could be a doctor from the outside. We will teleconference those people in, and we just want the people to submit their cases in advance so we can prepare the slides and the pathology slides and everything. We present anywhere from 4 to 8 cases presented in an hour. There are months when we have too many cases, we have to hold an additional tumor board. And these are often complex or unusual cases where multiple skill sets are required to offer optimal care for the patient. There's a certain humility for the tumor board, right? Because you're admitting that we can't do it just with one person. You need a lot of people to work together. And you know, it's a really invigorating conference. It's one of my favorite conferences because I'm reminded why I enjoy working at UCLA so much. And so I can't hide how proud I am of this team because everywhere you look at UCLA, you're surrounded by intelligent people who really want to help. And so you often get yourself stuck in this situation, not sure what to do, and then you present it to the tumor board, and the ideas that are devised there are much more awesome than any one of us could devise alone. And the goal is to arrive upon a consensus and formulate an action plan for immediate implementation. Right? We're not just sitting there teaching and pontificating. There is a little bit of that, but honestly, we're there to get work done. And then we we put this consensus into the chart. It's documented, and then there's a phone call or a video conference that takes place within 24 hours after the tumor board, where we convey the findings to the referring doctor and to the patient and their family. All right, so that's the basic structure. And I'm just going to go through a few example cases. And now, since you know that when we say to you, we're going to present your case to tumor board, you know what the people look like, you know what the conference looks like, you know what it's for. So here's our first case. This is a 26-year-old woman with a fairly large left thyroid nodule. FNA reveals it's a Bethesda 6, means very likely to be, it's a malignant aspirate, and that means the likelihood of thyroid cancer here is about 99%. And it's common for us to show the ultrasound images. So the radiologist will then say, see, here's the trachea, and here's the carotid artery, and here's the tumor here. And it's a fairly large tumor. It's distorting the capsule a little bit, but still inside the capsule. We didn't see any abnormal lymph nodes, and it's not an obviously invasive tumor. And so I'll turn it over maybe to Dr. Livhits to discuss these findings and what she might do.
Yeah, so we know that this is an almost 4-centimeter thyroid cancer. I'm assuming probably a papillary thyroid cancer. And this patient could be managed either with thyroid lobectomy, removal of half the thyroid, or total thyroidectomy, removal of the entire thyroid, based on the 2015 American Thyroid Association guidelines. So the things that I'm thinking about are the ultrasound findings that Dr. Ye already mentioned. It's a tumor that seems to have clear borders. We don't see local invasion or spread to the lymph nodes. So either option is reasonable. The other things I'm thinking about are there any nodules in the other half of the thyroid? Is the patient already on thyroid hormone supplementation, in which case there might be less benefit in leaving the other half of the thyroid in? And the patient's preference, the patient, how they feel about it. Are they somebody that prefers sort of more maximal removal of the entire thyroid to have a little bit more reassurance, potentially be able to use tumor markers after surgery, or somebody who really wants to try to avoid thyroid hormone supplementation and try to leave the other half of the thyroid in? So I think both options would be very reasonable in this patient. And I would discuss both options with the patient. I think there are pros and cons to either one. If you would make me decide, I think that removal of half the thyroid would be reasonable to start with, really in the absence of any high-risk features.
And for Dr. Leung, what role does the endocrinologist play in this initial decision for the type of surgery and extent of surgery?
Yeah, thank you so much. I'm pleased to join everybody here. If the patient is coming to see me before the surgery, sometimes I am involved at that point. Sometimes as an endocrinologist, we get involved after the surgery has been done. Either way is fine. But things that I might be able to help in the endocrine perspective before the surgery would be to counsel them that this person is a very young person, and age is so protective in thyroid cancer. Young people tend to do very, very well because it downstages their eventual, the outcome of the stage that's arrived after surgery. I also recognize that she's a young woman. There's obviously plans potentially for childbearing. So I ask about all of that because it might have some influence when we talk about subsequent treatment if it's required, if it's found that this cancer is found to be a little bit more aggressive or invasive after the surgery. But then I do what has been already implied and inferred is I refer to one of our endocrine surgeons. I always say that choosing an endocrine surgeon is important just because obviously there are potential risks with any procedure surgically. So I want to always reassure folks to find someone who's doing a lot of surgeries and with a lot of experience.
Yeah. So yeah, these are all excellent points that go into this. I'm cognizant of the fact that among the audience members, there are a fair number of people who probably had surgery prior to 2015, and we had sort of fewer options then, right? Most everyone then was getting a total thyroidectomy, often with radioactive iodine. And then there's going to be a generation of ThyCa and attendees who have now been managed with therapeutic lobectomy, right? They just had a lobectomy only if they had a tumor less than 4 centimeters in diameter without invasion and without positive lymph nodes. And I'm sure that's one of the new topics of discussion. There'll be a generational difference. So in this case, Dr. Livhits highlighted many of the factors that go in the decision. When there's ambiguity, I tend to do just a lobectomy when we're kind of on the fence, because I like to say to people, if we do a total and it ended up being not the right thing to do, we can't really put anything back in. Whereas if we do a lobectomy, it's okay to do a little bit more the following week if turns out you need to. All right, so this is what the pathology looks like. And you know, I know that some of you guys have all seen your pathology reports, but this is what the tissue actually looked like and it looks like. And you see these beautiful pink and purple colors. And this is, of course, not the natural state of the tissue, but the tissue has been stained with special stains to highlight certain cellular features. And this is a fairly classic papillary thyroid carcinoma. The normal thyroid has these big lakes of colloid fluid. But you see here that there are no lakes, it's mostly cells. So that tells you it's a neoplasm or a type of growth. Then, you know, some more details here. And especially these big white circles, which are the nuclei that look a little bit different. And so this was a classic papillary carcinoma. It's so nice, you know, whenever you meet with a pathologist and they describe to you exactly what's going on, you always get more information than you would from just reading the report. Likewise, when a radiologist describes to you blow by blow what's in a set of images, that's always better than a report. You can ask questions, you know, you can interact with them, so more information always comes forward. So this lady, we thought she had a 3.8 centimeter left thyroid nodule, but it turned out to be a little bit more than we bargained for. It was actually 4.3 centimeters, and one of the margins, a margin is like the safety factor you have between the tumor and the adjacent and sort of where you actually cut it out of the patient's body. And one margin is pretty close, less than a millimeter, though negative, right? We didn't have any tumor present at the margin, and one negative parathyroidal lymph node. So in this case, we had a little bit more than we bargained for. And you probably heard many times during this meeting that lobectomy is acceptable for a tumor less than 4 centimeters, but now it turns out to be greater than 4 centimeters. So Dr. Livhits, what should we do with this little surprise?
Yeah, so I think first it's an important point, as you already mentioned, if we're going to do a lobectomy, there's always a chance if we find something a little bit more high risk in the pathology that you will have to come back for a second surgery to remove the other half of the thyroid lobe. So going into it, that just needs to factor into your decision that you're okay with the possibility of potentially having that second surgery if we think it's necessary based on the pathology. And patients often ask, what is it that we're looking for in that pathology report when we're looking at the cells under the microscope. So we're looking at the type of papillary thyroid cancer. So classic is what most people have. That doesn't make it particularly more aggressive, but there are certain subtypes of papillary thyroid cancer, like tall cell, for example, that can be a little bit more aggressive. And then, of course, we're looking at the margins. Margins are less important for thyroid cancer than they are for some other things, other types of cancers. We do need to have negative margins, but we don't need to have a very large margin. We just need to have completely removed the tumor. So I would say this patient needs to go back to have the other half of the thyroid removed because it was already kind of on the border, but now we know it's over 4 centimeters in size, and we do have that close margin. I think we need to remove the other half of the thyroid.
Great. And for Dr. Leung, is there something magical about the 4 centimeter cutoff? Is a 4.1 centimeter tumor that much worse than a 3.9 centimeter tumor?
This is a good point, and not. We know biologically the tumor doesn't act suddenly more aggressively just because it's crossed over that 4 centimeter mark. But our recommendations to go back and remove the other side are based on available data, what people call retrospective data, looking at people who've had thyroid cancer and it be a little bit larger than 4.0 centimeters. That tends to be the situation which we want to guarantee complete removal. So I agree with Dr. Livhits that it's a good idea to go back and remove the other side, but not necessarily because we think you're at suddenly high risk.
Yeah, it's just sort of a result of how we study these things in terms of research. And Dr. Livhits, like when would we do the second operation? And is it worse? Is it higher risk to have 2 operations as opposed to 1? Is it bad?
Right. So there are 2 factors. One is the surgical factor. So in terms of timing, ideally for the second surgery, we'd like to go back almost right away within a week or so before there's too much scar tissue that sets in. Sometimes we can't do that right away for whatever reason. The patient needs a little bit more time to recover. There are some logistical factors. In that case, we would want to go back after 6 weeks. That time in between, things are very sticky in the neck. There's a lot of scar tissue, and that can make the surgery a little bit more complicated. So we either want to go back within a week or so, or wait until all that scar tissue settles down, and then after 6 weeks. In terms of the actual complications, they're really fairly similar to the initial surgery. We go back through the same scars, so you don't need a new scar. We just open it back up. And the good part is that whenever we remove one half of the thyroid, we really don't go to the other half of the thyroid in that deep space. And that's purposeful. It's to avoid creating scar tissue in that area. So when we do go back to remove the other half, we really haven't been in that deep space before where the critical structures are, the vocal cord nerves are in that area. So the risk of complications in that second operation is fairly similar to the first one.
I notice that the patients always say the second time is easier. I think it's because they kind of know what the deal is. They walked that path before. All right, so this one, it was on the margin. The patient needed a little more time. So we decided to test this patient's tumor for mutations. And we found that it was positive for the BRAF V600E mutation. So Dr. Leung, can you tell us a little bit about the significance and the prevalence of this mutation? And should patients be worried if they have it?
It's a little bit of a complicated question just because we don't necessarily advise getting this mutation tested in everybody before the surgery happens. And the reason for that is just because if it is found, and it's found quite variably, studies say maybe it's found in up to like even 80% of the time, but it could be as low as 30% of the time. It really depends on which groups of patients you're studying and all sort of different conditions, age groups, and all that sort of stuff. So even if we were to find like this person had the information, it doesn't necessarily change that much in terms of how we counsel her risk of recurrence of the disease, recurrence of the thyroid cancer in years to come. It alone itself doesn't probably predict enough information for us to say confidently it will, recur in this this degree, this percentage. But what we use it in and where it's helpful is if we put everything together, her entire package, right? Her age, other features of the tumor, the size of the tumor, whether or not it was completely excised, all that sort of stuff. where it itself, in addition to all of those clinical factors, can perhaps inform her risk of recurrence. So again, important to stress that we don't necessarily want to test for the mutation everybody before the surgery.
Great. So we were kind of on the fence, and we allowed this to kind of push us over. And just like Dr. Livhits said, we did do a completion thyroidectomy. And then we had some labs. So one question that we would pose to the tumor board in this patient's case is, should we do the completion if it's ambiguous? And the other one is, should we give radioactive iodine? Because everything about this case is kind of on the margin. It's kind of gray, and we could go either way. So 1 month post-op, she had a TSH of 0.99, which is in the normal range, and a nice low thyroglobulin with negative antibodies. And you probably remember that the absence of antibodies really allows us to fully interpret this number, the thyroglobulin number. And we thought 0.6 was pretty good. And we waited a little while longer because the patient was unsure in discussions with her endocrinologist whether or not she wanted to have radioactive iodine. And her TSH, you see here, got a little bit more suppressed, and her thyroglobulin went down to 0.2. And I pulled this data from an encounter from just a few days ago, and the endocrinologist says the thyroglobulin of 0.2 indicates a very thorough operation. And that made me feel so warm and fuzzy, because, you know, surgeons, we need love too. And so I was asked Dr. Leung, if you see these TSH and thyroglobulin numbers, how does that influence the decision for radioactive iodine in this case?
Oh, this is so reassuring. I like to see thyroglobulins, you know, definitely less than 1 or fractions of that. So we are already there so quickly after thyroid surgery has been completed. And that, you know, that number really equates well with how much thyroid tissue is remaining, whether or not that thyroid tissue is cancerous or regular thyroid tissue is remaining microscopically. So there's really almost nothing left. So sometimes we talk about using this separate treatment called radioactive iodine in some people to get rid of even more microscopic stuff, but we already shown that amount is almost negligent. So I would say that she is not going to be benefiting much more from dosing radioactive iodine. I would counsel her that we don't necessarily need to do that. In terms of her TSH, that reflects how much thyroid hormone replacement the person is on. So sometimes we, at least initially after surgery, we give them a little bit extra levothyroxine, a little bit too much thyroid hormone replacement to just to try to keep the thyroid cancer away, in terms of any thyroid cells that might be remaining to not be woken up and stimulated to make thyroid hormone. So I like a TSH that's sort of in that range, a little bit lower than normal, around 0.1, and for her, probably even up to 0.5 would be fine.
Yeah, this is something relatively new, you know, for patients who could go either way in terms of radioactive iodine or not. I find that more of my patients, we're waiting, we're checking the thyroglobulin, and we're seeing whether or not that thyroglobulin level is reassuring. Dr. Livhits, are you seeing a similar pattern? What role does the early post-op thyroglobulin play in your patients?
I absolutely agree. I think we have more of these patients that are a little bit in a gray area. There might be some slightly higher risk features, like this patient had a tumor over 4 centimeters. It did have the BRAF mutation, which has been associated with slightly more aggressive papillary thyroid cancers. However, that's more in older patients and more in male patients. So in a young woman who already has an excellent prognosis, you know, she's a little bit in this gray area. So I think that thyroglobulin level, when it comes back, you know, 4 to 6 weeks after surgery and is already very low, we feel fairly confident that there's no more disease at the time. And I would just mention, this is one of the benefits of the tumor board, is that we can immediately get multiple opinions from different endocrinologists and surgeons in a very efficient way. So rather than the patient, you know, potentially, let's say, you know, you want to know maybe what somebody else might think, and you would go to a separate consultation, you immediately have that entire room full of experts that can look at your specific case, all of the details, and give a group consensus.
Yeah, it's really, the tumor board is like getting 25 second opinions at the same time for free. And sometimes there are disagreements, you know, people have to arm wrestle a little bit. But it's good to have a diversity of opinions. So in this case, you know, what I'm thinking is, you know, not all surgery is perfect, right? So I'm wondering in every case after I finish, is it possible that I could have missed something? And there are two ways you can miss something. You can miss it because you didn't see it on the ultrasound, or you can miss it because it was there on the ultrasound, but you didn't remove it. The presence of a thyroglobulin of 0.2 means that neither one of those things happened, right? It means that we have a complete resection. And what's amazing to me is how sensitive. Thyroglobulin tests are so darn sensitive now. They can detect, I often say it's like a smoke alarm who can find, there's a guy smoking one cigarette down the block from you and your smoke alarm can pick it up. So in this lady, we've decided to hold at this position. And so that's the end of the first case. And for our moderators, Anjali and Joel, are there questions that have bubbled up about this first case that you think we should answer? Maybe we'll take two of them or so.
So not exactly specific to the cases, but there was a question about from Kelly about, do all major cancer hospitals have tumor boards, and do they use these boards with all patients or only with patients that have the most difficult tumor situations?
Yeah, so I would say a lot of major hospitals do have tumor boards. Ours is specific for endocrine tumors. And that's not present at all hospitals, right? But it would only make sense to have an endocrine tumor board, which is about like 90% thyroid cancer of the cases that are presented. It would only make sense if you have enough cases. And do we present all the cases? No, because at UCLA this year we might see 400 patients or so. It's hard to estimate, maybe 400 patients with thyroid cancer. And we only present like no more than 8 cases a month typically. So it's the ones that are unusual, or the ones where instead of like 1 or 2 people, because a lot of tumors between the endocrinologist and the surgeon, a lot of those tumors can be managed just with a team of 2, right? Easier to hop on the phone with that person. But if you need a team of 2, 3, 4, 5, 6, then it's a little more complicated. Or cases that are nuanced, or we have a specific question, or we want to teach the group, right? So something else that happens here is collective learning. We all learn that, hey, BRAF mutation testing is available. It can turn around at this amount of time. This is how it influences the decision making. And it lets me step into the shoes of the nuclear medicine doctor. It lets the radiation oncologist step into the shoes of the endocrinologist. So this is how we all learn from each other. So we will do it for a complicated case or a case where we really think there's an important learning point for us to share. Is there a second question we can take, Anjali?
Sure. There's someone who had a Hürthle cell carcinoma with a margin that was less than 1 millimeter. Is that something that would be concerning, or not?
Question about close margins, which I'll turn back to Dr. Livhits.
So again, with thyroid cancer, including Hürthle cell carcinoma, the main goal is negative margins in general. Yes, a very close margin, there's a little bit of higher risk potentially for a local recurrence in that area, but as long as the tumor was completely removed, that's the most important thing. For Hürthle cell cancers, our main concern is that they can spread through the blood to distant sites. So we're worried about that more than a local recurrence. So again, that close margins probably a little bit less important, but Hürthle cell cancers do tend to produce a lot of thyroglobulin. So that is a very good cancer marker to follow for Hürthle cell cancer. And that would be high if there was any remaining Hürthle cell cancer who was coming back locally in the neck or in a distant site.
And Anjali, shall we take one more question or move on to the second?
Sure. We have got one that's sort of related to the surgery that you spoke about earlier. And why didn't the surgeon go ahead and remove the entire thyroid when they were doing the first surgery and saw the tumor was larger than 4 centimeters?
Yeah, it's hard to know exactly how big it is. It's just a few millimeters off. So sometimes, yeah. So would we so that's a great question. Why didn't we immediately go to a total thyroidectomy? It was, kind of on the border. We're gonna wait for the pathologist to measure it. And then, a lot of it comes to what sort of conversation did you have with the patient before? How well did you prepare them for this possibility? There are some patients who are like, doc, you do whatever you think is best in there. And there are other patients who just say, I really don't want more than one lobe removed. And you got to respect that patient's autonomy and decision making. You know, we're always there to do what's best for that patient. Something that makes life a little easier is if there is a designated decision maker. And so, you know, there are some cases where we have to make it happens maybe a couple of times a year where we've got to make a key intraoperative decision while the patient is sleeping. And it really helps if I know that this patient has a, you know, a decision maker that I can speak to during the case. But yeah, there are moments when we have to change the plan in the middle of surgery. But I'll be honest with you, most of the time, a really good ultrasound that we tend to do ourselves, the surgeons tend to do ourselves at UCLA, that takes most of the guesswork out. Did you want to comment on this point, Dr. Livhits?
Yeah, I'll just add, I think it's very important for us to be on the same page before the surgery, for us to really understand what your wishes are, what your priorities and values are. And then that way we can make a decision during surgery, if that's necessary, based on your preferences and your values. Of course, it has to be medically appropriate. But in cases where you can go one way or another, we really take the time to talk to you before the surgery to understand, you know, as best as we can what you would want in that circumstance, so that we can do that. And,
Yeah.
you know, in a case like this, there's no way for us to know exactly the size of that tumor. The pathologist is really the one who they measure it very carefully. They look at the cells under the microscope. So we can't tell that until the pathologist takes a look at it.
Yeah. There are some things that are obvious. You know, there are times when a tumor is clearly just coming outside of the surface and grabbing onto muscle, or there's most often we would see that on ultrasound. There are other times, and Dr. Livhits and I had a few cases of this every year, where there's some little lymph nodes, but they're clearly not normal lymph nodes and not big enough to show up on the ultrasound, but they've got a funny color about them or a pool of colloid fluid in them. And so sometimes a negative lymph node, a surprise finding of an abnormal lymph node during surgery, will flip a case from a lobectomy into a total thyroidectomy plus a lymph node dissection. Sometimes that happens. Okay, I think we're just going to do 2 cases today because I think the discussion is really good. So I'm just going to go slow. And this person may or may not be in the audience today. Okay, 75-year-old woman when I met her. And presented for follow-up of papillary thyroid carcinoma believed to be metastatic to the lungs. And she had her first operation somewhere else. This was a total thyroidectomy and a central neck dissection. And pathology showed multifocal papillary thyroid carcinoma. That means multiple islands of thyroid cancer within the thyroid. But most of the action, the big one, as you can see, was on the left lobe. And the biology of papillary thyroid cancer, most cancers are dominated by the largest focus, usually. There was a 1.3 centimeter focus from the right, and 3 out of 4 positive lymph nodes measuring up to 5 millimeters, and none of them at the time had extranodal extension. Extranodal extension means you got this lymph node, and the fingers of the tumor, little roots of the tumor, are coming through the surface of the lymph node. And that's an independent risk factor for a tumor coming back. She did have radioactive iodine, and she had a post-therapy scan which showed high concern for metastatic lymphadenopathy in the thyroid bed. So some lymph nodes were still glowing, and in the left chest. However, her thyroglobulin was pretty reassuring. So here we have some conflicting data. And Dr. Leung, how should we interpret that? There's a post-therapy scan showing some worrisome areas, but the thyroglobulin is pretty good. What do we make of this?
Yeah, this was maybe what Dr. Livhits had alluded to earlier, that not all types of thyroid cancer are able to make, thyroglobulin as our tumor marker robustly. And sometimes, especially when the thyroid cancer turns into a sort of what we call a less differentiated thyroid cancer, it tends to secrete very little thyroglobulin. So this is a little bit of a mismatch here. We recognize that. This is why we don't use one test in isolation. We do imaging along with blood tests for thyroglobulin together. And if there's a mismatch, then we kind of go and sort out the answer of what that might be.
Yeah, excellent point. Yes, some tumors are more efficient at secreting thyroglobulin than others. All right, so this is when I met her, 2015, and then suspicious cervical lymph nodes were found doing a routine ultrasound surveillance exam, and a needle biopsy was performed of these abnormal looking lymph nodes, which showed cellular smears of atypical follicular thyroid cells and it looks like papillary thyroid carcinoma, and the nuclei are a little weird. And this FNA result is basically a home run for a thyroid cancer in a lymph node. And maybe I'll turn it to Dr. Livhits at this point. What would you do for this patient? And I just want you to know, she was 75 at this time, but really very active, totally healthy, robust, wonderful family life, and highly functional.
So first, I think this highlights the importance of imaging, not just the tumor markers. As Dr. Leung mentioned, some tumors produce less or more thyroglobulin. So it's really the combination of the blood testing for the tumor markers and the imaging. And the ultrasound in particular is really the best imaging modality to look for a recurrence or cancer coming back in the neck, typically in the lymph nodes or perhaps in the soft tissue. So in this case, the thyroglobulin wasn't such a great marker to pick up the recurrence, but it's really the ultrasound. So we know there's a recurrence in the neck. But the next point I'll mention is, again, the benefit of the tumor board. This patient had their initial treatment somewhere else. So the tumor board presentation really gives us an opportunity to go and collect all that data that we may not have otherwise. We're going to go back and really look for the prior reports of pathology and find the radiology images and kind of go back in time so we get that full history, and we present all of that during our tumor board so everybody is up to date on that. In terms of what to do next, I would first evaluate, how much disease does the patient have, and is there still concern about disease outside of the neck? And we had, this patient had spread to the lungs. So I'd probably want to know what is the extent of metastasis in the lungs, and then what is the extent of disease in the neck. But if the disease in the neck, I thought, was something that could hurt the patient, depending on the location, could there be invasion into a major blood vessel or perhaps the trachea? That is something that could really hurt the patient in the near future, and that I would consider a reoperation in the neck to remove the disease and the potential complications from a local invasion.
Yeah, excellent points. We, in this particular case, we were not really able to confirm a significant amount of disease in the chest at this time. And it seemed like the thyroglobulin was a little low. It didn't seem to quite fit. A thyroglobulin for a patient with a significant amount of lung disease, I would have expected a little bit more than a thyroglobulin of 1.1. Dr. Leung, what do you think about that? I mean, how do we interpret the thyroglobulin number? Could we convert that thyroglobulin number to an approximate volume of thyroid cancer present in someone's body?
Yeah, we can, but only under the caveat that if that tumor or the collection of tumor in aggregate in the body is efficient in making thyroglobulin. So we roughly translate, the thyroglobulin units into how many grams of thyroid tissue are remaining in the body. And so, as Dr. Ye had suggested, a thyroglobulin of 1.1 translates to like only 1 gram of thyroid tissue, which is like nothing. So this is where our radar pops up and says, is something else going on, and why isn't it making it thyroglobulin?
Yeah, and a gram of tissue, I sometimes think like an M&M, right?
Yeah,
Because Halloween's
really
coming up,
little.
we use candy analogies. All right, so we did perform a left neck dissection, and something Dr. Livhits alluded to is if this patient had widespread disease outside of the neck, we probably wouldn't be operating in the neck, because we have some treatments that are focal, where we're doing surgery or we're blowing away one little area of tumor, and that's good if we think the disease is limited to one area. If we think the disease is systemic and spread throughout the body, it doesn't quite make sense to pursue a focal therapy in that case, unless the patient's having symptoms like a metastasis in the hip that makes it painful to walk. We would perform a focal therapy for that, probably a radiation treatment, in order to restore the patient's function. All right, so this patient did have focal treatment, redo left central neck dissection, and Dr. Livhits, I found this. I found tumor invading the left sternocleidomastoid muscle, which is this diagonal muscle here, which was easy to remove, several left central neck lymph nodes, which were easy to remove, and then I found a little, like a smaller than a kernel of corn area of tumor, which was involving the left recurrent laryngeal nerve, and I had to make a choice whether or not I wanted to sacrifice the voice nerve or leave it alone and leave a little tumor there. And I know you've been in that position. So what is your thought process when you see something like that?
So yeah, this is always a very difficult situation. Sacrificing the recurrent laryngeal nerve means that the patient could have some hoarseness after surgery. There are procedures that we can do that can improve the quality of voice, but it does have some real consequences. So I would think about the patient's entire situation. This is a patient who's 75, I think you said, and who this is their second operation. There was some concern about spread outside of the neck. So I don't know that we're talking about a curative situation. You know, if this was a young person and sacrificing the nerve to remove this tumor would achieve a complete cure, then I would be much, really considerate in that case. I think that in this case, I would probably prefer to leave a tiny bit of tumor along the nerve to try to just protect the patient's quality of life, because I don't think this is going to be a definitive cure. I think the patient's still at risk for some disease coming back or perhaps being in the lung still.
Yeah, great point. Great point. So yeah, that was my reasoning. I thought, she's 75 at the time, and I thought she was unlikely to have this little area of tumor end up shortening her life or causing significant morbidity. And I did think there was some risk, lurking in the back of my mind, the possibility of lung disease. So you'd hate to sacrifice a nerve, give somebody really a permanent disability, hoarseness. We can rehabilitate the voice, as you said, the things we can do, but it's never perfect. I hate to do all that, cause a significant disability, and still have tumor present in the chest. So yeah, I did leave a small amount of tumor on the nerve. I spoke to the family and the patient extensively about this, and we agreed that we would just monitor that area with ultrasound every year. And so this is what the full pathology report looked like. There was tumor invading the muscle. This is a positive margin, so tumors present at the inked and cauterized specimen edges. Cauterized means we use this little heater probe to cut through tissue sometimes. But when tumor invades into muscle, it's hard to get a negative margin. She had a lymph node that was positive, a couple other lymph nodes were positive. And here you see the extranodal extension present. So tumor starting to crawl out, getting his little fingers outside of the lymph nodes. All right, so I'll turn it over to the group. What else does this patient need? And maybe for Dr. Leung, how do we decide focal versus systemic treatments? And this patient went on to do well for quite a few years. So what would you say in the tumor board? Would this patient need anything immediately to follow this operation?
Well, we have the luxury of looking back at her case, and it's nice that she did so wonderfully. But at the time, had we been, back in time at the time of this case, further treatment is going to be sort of an individualized decision that probably, her team of the endocrinologist, as well as her surgeon, her family is going to probably want to be all discussing in detail. Are we talking about quality of life that we want to preserve, or do we really want to eradicate every last trace of tumor and, perhaps alleviate any anxiety if that is an issue in her life? When we talk about focal versus systemic treatments, focal treatments can be, either getting rid of the tumor that we can see. So like, let's say surgery for local areas, or using something called external beam radiation using a beam from the outside, not something that she had already, that radioactive iodine dose that she swallowed by mouth a couple of years ago. Versus systemic treatments, those are what we refer to as generally infusions of anti-cancer treatments that target the thyroid cancer no matter where it is in the body. So an infusion in the arm through the vein every couple of weeks or so. The decision to do the systemic treatments would be a little bit more intensive. It comes with a lot of side effects. And it may not necessarily cure her. We know she has a pretty extensive amount of disease, but at the same time, it seems really small and stable and perhaps focal. So using one of these large guns might not be in her best interest. So there's no one right answer for her, and this is where we have just a really good conversation about her expectations and her wishes going forward.
Yeah, that's a great point. This patient tended to prefer less treatment. She had a very supportive environment, always came to her follow-up appointments. So it was a good person for us to be able to monitor with accurate surveillance. And she, in retrospect, it was doing nothing and just observing her was the right thing to do, because 3 years went by and nothing at all happened. This is an 11-year journey I'm presenting to you. And I know that the people in the audience are all on long journeys. Thankfully, the survivorship after initial treatment for thyroid cancer is so good, right? And so we have the luxury of talking about these things. And so here are some of her numbers. And maybe I'll ask Dr. Leung to help us interpret some of these values.
Okay, the big numbers that we are looking at is the thyroglobulin. That becomes our tumor marker, right, in a person who's had their complete removal of their thyroid glands. And we can see that it started off at 1.1, and the tumor burden seemed to increase over the years, 3.6, 18.3, and then 45. Everything is relative. We can't sort of translate to say that 45 is the same type of morbidity, meaning the same health effects in one person versus somebody else. Someone can be completely asymptomatic with that amount of thyroglobulin versus someone else who may not be. It really depends on where the tumor has sort of recurred and spread to. Is it really close to vital structures and that sort of thing? The thyroglobulin antibody, as Dr. Ye had mentioned previously, we always get that just to be able to trust the thyroglobulin itself. So it's nice that that thyroglobulin antibody was negative. And then the third value is that TSH. Again, just to remind everybody, that's a reflection of how much thyroid hormone replacement we're giving her through the synthetic pill. And so we weigh the risks and benefits of having too much thyroid hormone replacement on board versus just enough to fill the tank. I talked about previously that having too much really tries to keep the thyroid cancer away, but in an older person like this patient is, it can also have some detrimental effects to the heart and the bones specifically. So we weigh the risks and benefits of keeping her TSH too low, but yet not giving her other health problems. So I like this TSH right where it is if she's feeling asymptomatic.
And Dr. Livhits, when you look at these numbers, especially that rising thyroglobulin level, what does it make you think? And if you were to start looking for tumor, where would you look?
Yeah, so this is a very clear pattern that this thyroglobulin is going up. And when you look at the doubling time, I mean, it's going up, a fair amount. And now this thyroglobulin in the 40s certainly makes me think of disease outside of the neck. So spread outside the neck, perhaps to the lungs.
Yeah, so I agree. When I see a thyroglobulin like in the single digits, I'm thinking a neck lymph node, double digits, maybe the lungs, triple digits, maybe the bone or somewhere else. So we started looking, and we started looking in the chest because, way back when we had some indication there was a little bit of disease in the chest. And indeed, she had a chest CT demonstrating numerous sub and pericentimeter non-calcified pulmonary nodules throughout both lungs. And I tried to pull up the images to show the audience, but I couldn't get the website to work. But this just looks like, remember, the lungs are mostly air, right? And on our scans, air looks black. Solid tissue looks white or gray. And this was like little dots, little teeny dots spread in several areas throughout the lungs. And this did look like a pattern compatible with a small amount of lung metastases of thyroid cancer. So this is a case we brought to the tumor board, the April tumor board. And so what should the next step be? And I'm going to ask Dr. Leung to pretend to be maybe one of the radiation oncologists or the medical oncologists in our group. What would that discussion look like?
Yeah, and this is where we really appreciate the expertise of so many disciplines in the room. But how we think about something like this is we try to figure out how many discrete areas in the lungs might be cancerous versus sometimes people just have pulmonary nodules in the lung for, just a little bleb of something that is not cancer. And indeed, from the imaging, if it looks like, there's lots of diffuse tumor, then it would be really hard to remove that, let's say by surgery or through this really focused beam of external beam radiation that a radiation oncologist would be responsible for delivering the care for. So if it doesn't look like, it's really one area that we can really eradicate through one of those means, and if the person herself, she's getting perhaps a little bit more symptomatic, we ask about her breathing. Sometimes we do some specific breathing tests, a pulmonary function test to see how much air she's able to move through the lungs. If all of those things seem to be, suggestive that she's really symptomatic, that her health is being impacted from these little lung nodules, then this is where we would consider referring her to one of our medical oncologists for one of these systemic therapies that I talked about recently. So it really kind of depends on her situation, asking all those questions.
Yeah, so she was
Dr.
totally.
Dr. Ye, we've got about 10 minutes officially left.
Okay.
We can run over a little bit.
Okay, all right, thank you for that tip. Yeah, so Dr. Leung mentioned that these little dots can be thyroid cancer, but they might not be. There are other reasons to have these little dots in the lung. There are certain fungi or other infections that can cause it. So maybe I'll ask Dr. Livhits, do we need to prove that this is thyroid cancer before we give the patient any other treatments, potentially toxic, chemicals with side effects, or do we need to prove that?
Yeah, generally the radiation oncologist and the medical oncologist, they do want a biopsy that proves that there is metastatic disease before they treat with a treatment that can have some side effects like a systemic therapy or radiation. And usually the biopsy of the lungs can be done in a fairly minimally invasive way, guided by CT imaging. So it's not a surgery, but we should get a biopsy of the lungs next.
Okay, so that's what we did, and it's amazing. These little dots are so teeny, like a little corn kernel, and yet the interventional radiology guys can guide a needle into that without puncturing the lung. I don't know how they do that, but they were able to spear this little thing, and it showed metastatic papillary carcinoma. And again, we love the pathologists always helping us. They stain it for molecules that are only present in thyroid tissue. And these TTF1 and thyroglobulin markers are both positive, and that proves beyond the shadow of a doubt that this is metastatic thyroid cancer to the lungs. And so here we are, brings us up to today. Now she's 80. Small volume in the left neck, and I should tell you that we ultrasound that area every year, and it's a tiny little speck, but it's now a little bit of an M&M, in the neck. Thyroglobulin trending upwards, which stimulated us to look at the lung, and then we found some lung nodules, and we biopsied these showing metastatic cancer. But the patient's doing great. She's doing great. Doesn't feel anything. So what are the options now? Maybe Dr. Leung could comment. Well, we could give a systemic treatment. We could give chemotherapy. What about radioactive iodine in this patient?
Yeah, I think the key is that she is doing well, so well clinically that we really have to weigh the risks of introducing one of these, other therapies that have oftentimes been associated with side effects and, decreased quality of life from that point onward. And also with the sense that we likely, no matter what therapy we choose, if any, will be unlikely to totally eradicate her tumor, right? We won't ever sort of get rid of it completely, but it doesn't mean that she won't be fine with that little bit of tumor resting in her. So Michael had talked a little bit about radioactive iodine. She had one round of it many years ago, more than a decade ago. Could her disease be receptive to receiving another dose and potentially getting rid of a little bit of that tumor? We would try to do a diagnostic radioactive iodine and scan if that was a consideration before we give her the real dose, if so. But, in terms of talking about these systemic therapies, what we call, chemotherapies for thyroid cancer, it seems like that the risks would really outweigh the benefits in this situation if she's doing so well. So we had many patients exactly like her who have a little bit of thyroid cancer in the lungs or elsewhere. We just monitor them, every 6 months or so for years and years on end, and they tend to do quite well. So I would maybe leave it at that for her.
Yeah, all these options. And I think this is your point, if I'm hearing you right, is this is an example of living with cancer, a small amount. And this patient is clearly thriving. And it's one of the most pleasant aspects of treating people with this disease is you were friends with them for so long, and you see them live their lives and have fulfilling activities and relationships on the journey. This patient did have a second dose of radioactive iodine, and the post therapy scan. So we give the patient a dose of radioactive iodine. We wait about 5 days, and we do a post therapy scan, and we see did those tumor areas drink up the radioactive iodine? And yes, it did. So here we have focal intense radioactivity in the left upper lobe, corresponding to a lung granuloma. That's a collection of inflammatory tissue favored to represent reactive change versus less likely melanoma. Sometimes there's some ambiguity as to whether or not it's truly an area of thyroid cancer, but they had some iodine uptake in the lungs. And I felt reassured by this. I felt like the thyroid cancer cells there were taking up the radioactive iodine. And so here are her tumor markers. After that peak of 45.4, it did come down a little bit. And is it safe to say, Dr. Leung, that maybe she had some response to the radioactive iodine? Too early to say?
I think that's true. Radioactive iodine can stay and be effective in the body for up to a year. So the time frame of this calendar seems to fit that response. But again, as we said, it's unlikely that we'll completely eradicate her tumor as long as this number sort of stabilizes, remains kind of in this range. We're fairly happy with that.
Very good. So that brings us up to date with this patient. So we're happy to take some more questions from the audience.
Great. We had a few questions that were asking about kind of the ideal thyroglobulin numbers, anywhere from 4 to 6 weeks. What are they looking at? As well as trying to determine well, let you run with that one as far as like the ideal TG. What are we looking for?
What's a good thyroglobulin level 4 to 6 weeks after surgery? Dr. Livhits, you want to comment?
Well, the lower the better. We would love to see it be undetectable. That's like an A+ score. That's not necessarily what happens so soon after the surgery at 4 to 6 weeks, but certainly some of our patients do have an undetectable thyroglobulin that soon after surgery. We'd like it to be below 1, especially if the patient has, obviously has not gotten radioactive iodine or not gotten it yet. So ideally below 1 if they haven't gotten radioactive iodine.
Important to stress here that number is only applicable to a person who's got their entire thyroid removed. So we would not be wanting to measure a level because it would be high in a person who's had half.
Yeah, so that's a great point. We're seeing more and more patients who have lobectomy as their definitive thyroid cancer operation. And a big question that's lingering in all of our minds is how do we interpret the thyroglobulins in those people, right? So those thyroglobulin levels, I've seen them 2, 5, 20, because remember that normal thyroid tissue makes thyroglobulin rather efficiently. My personal opinion is it's going to be really hard to interpret thyroglobulin levels as a tumor marker in those patients because most of the thyroglobulin in that patient's bloodstream is going to be made by normal thyroid tissue, right? And that's essentially noise for us. That's noise, static on the radio. Whereas thyroglobulin produced by the tumor would be the signal we're listening through, but there's so much noise, it'd be hard to hear that signal, in my opinion. So patients who have lobectomy, first of all, you got to choose your patient well. Choose a patient who's going to have a low likelihood of recurrence. And next, imaging for surveillance, really imaging dependent. Did you have any other comments, maybe Dr. Livhits, about how you follow these patients with a lobectomy?
I absolutely agree with that. And I think that's why, again, selecting the patients appropriately, they have to have a low risk of recurrence in the first place. And they have to feel comfortable with that because our, only real tool to monitor for recurrence is the ultrasound. And it's very accurate for this. But if it's a patient who really wants that extra reassurance of having the thyroglobulin, we have to know we won't have that if you have a lobectomy.
Maybe we'll have time for 1 or 2 more questions on Dali.
Sure. Well, I know we've had on a few other forums as well, some folks who were looking for suggestions for treatment, and they have a specific variant, the hobnail variant.
Yeah, question about hobnail variant. something
I
we
think
don't see that often. Dr. Leung, did you want to comment on hobnail variant?
Sure. I have a couple of patients with this. It's as Dr. Livhits alluded to previously, most of the papillary thyroid cancer is going to be classic variant, like close to probably 90% or more. But a small number of people with papillary thyroid cancer are going to have these either tall cell or columnar, insular, hobnail variants. These tend to be a little bit more aggressive. So depending on the person's age and the pathology report, how many lymph nodes were involved, were there any margins, et cetera, we usually probably would recommend doing the completion thyroidectomy, removing the other part if only half has been removed. And then if the entire thyroid gland has been removed, sometimes we think about radioactive iodine at a lower threshold than would be. But many patients I have with hobnail, I haven't given radioactive iodine to, and they are several years out and doing fine.
Yeah, I would add to that, that there are reports in the literature of these patients having more aggressive disease, but the reports have very small numbers of patients because this is so rare. So I don't think it's applicable to all patients. I think if the tumor is otherwise very low risk, small 1 or 2 centimeter hobnail variant with no lymph nodes, that probably is not that different than a regular papillary thyroid cancer. Of course, a patient who presented with large lymph node disease, that's going to be more aggressive. So yes, there are reports that it's a little bit more aggressive, but with the caveat that it's rare and data is very limited.
Right. Yeah, we have to be cautious about admitting what we don't know. When the numbers are small, and this is a terrific note to end on that Dr. Livhits mentioned, because we really, the hobnail variant is just one data point. Whether or not you have BRAF V600E is one data point, but the truth is that we have a portfolio of information on this patient, right? We know the age of the patient, the size of the tumor, the ultrasound characteristics, whether or not the lymph nodes were positive, we have the pathology information. Like, in my mind, one of the things that's so important is we have knowledge about how this patient responded to initial treatment, right? So if after surgery and your thyroglobulin is really low, or you have surgery and radioactive iodine and you're 1 year out and you've got the ultrasound that's clean and the thyroglobulin that's good, all these things are little arrows we can add to our quiver. And as physicians, and even as a tumor board, we don't look at just one point. We try not to get overly swayed by one point. We have to look at that entire portfolio. And I hope we've given you some reassurance today that, when we're having the tumor board, you might be comfortably at home having a cup of coffee, but we're still working on your behalf, sometimes working really hard, and this work goes on behind the scenes. It's extremely rewarding. And if anything, I hope we've given you some reassurance just how much these big groups of people we really care about how you do long term.
Well, I'd like to thank all three of you. This has been a wonderful discussion, and looking forward to hearing more about tumor boards in the future.